Welcome, ladies and gentlemen. Welcome. Thank you so very much for joining us today. My name is Natasha Morano, and I'm pleased to welcome you here this afternoon. I'm delighted to see familiar faces in the audience and so many parliamentarians here today, so thank you very much for coming. I would first like to begin by acknowledging the land on which we gather is the traditional unceded Algonquin territory. We at the Economic Club begin every event by extending our respect to all First Nations, Inuit, and Métis people for their valuable past and present contributions to this country and stewardship of this land. We are grateful to be here today to gather for this important event. Today we will hear from a dynamic group of individuals who will discuss the most important issue currently facing the patient community in Canada, the new federal drug price controls. Specifically, the panelists will discuss the impacts the new price controls have on patient access to medicines and clinical studies in this country. Now, I would like to provide a little bit of context as to why this event is so important to me. 5 years ago, I had the privilege of being introduced to the Canadian Organization for Rare Disorders, and we subsequently traveled the country discussing a strategy for Canada's rare disease for Canadians. It was highly effective in achieving 5 goals, but 2 goals were specifically of interest to me. 1, access to therapies, and 2, the promotion of innovative research. Little did I know that a few years after our Pan-Canadian tour, my mom would be diagnosed with multiple myeloma, which is a form of cancer, and I would become her advocate. Well, ladies and gentlemen, if it wasn't for the power of innovative research and innovative therapy, my mother would not be alive today. I am so grateful for what I've learned working with Durhan and her team. The power of advocacy is truly life-changing. And so, as I stand here on World Cancer Day, which is anchored on the theme of I am and I will, I want to thank each of you in this room today for participating in this very important event entitled The Fight for Our Lives. I would also like to pay tribute to a very special young man I had the privilege of meeting in this room not too long ago. Ottawa's butterfly boy, Jonathan Pitra. Now, many of you were probably in that room a few years ago and inspired by Jonathan's courage and strength and advocacy for all Canadians affected by rare disorders. Although he has spread his wings, his spirit will absolutely live on forever. Tina, Jonathan's mom, is here today. I'm absolutely honored to have you in the room, and I applaud you for all of your incredible advocacy. Ladies and gentlemen, please join me in giving her a round of applause. I would like to thank the Canadian Organization for Rare Disorders for sponsoring today's event and for all of your incredible work. A big thank you to our annual partners who enable us to have important conversations like the one we're about to have today. Thank you to our volunteers, Devlin and Kathleen. I simply could not have put this event on without you, so thank you for all of your help. Now, the Economic Club is this country's national podium of record. Annually, we host close to 100 events from coast to coast, and our goal is to bring Canadians together to talk about the most important issues of the day. We are a club for all Canadians, and we have a mandate to include youth in all of our discussions through the work that we do via the Junior Economic Club of Canada. To date, we have engaged over 50,000 kids from across the country. And just a few weeks ago, we hosted President Obama in Toronto, and there was over 3,000 youth that participated in that event from across Canada. This is something I'm very proud of. And I'd also like to welcome the youth that we have in the room today. To the students that are here from various universities and academic institutions, thank you for being here and for your interest in this topic. We really do appreciate your presence. It now gives me pleasure to turn the podium over to Dr. Durhan Wanrieger, President and CEO of the Canadian Organization for Rare Disorders, who will officially get things started. Please join me in giving her a round of applause.
Thank you very much. And you know what? I got a mic on here. I may just step aside. Natasha asked me first, are you going to speak from the podium? I said, it depends on how high it is. Exactly. So I really hate being a disembodied voice to anybody. So I appreciate this very much. And I also feel a little bit better in terms of being out here. I won't take a long time to introduce it, but I certainly want to thank the Economic Club for providing this opportunity for us. And really thanks to Natasha, because she did travel across the country with us when we launched Canada's Rare Disease Strategy. And I'll just do a quick word of advertisement, okay? On March the 9th and 10th, we will be hosting CORD's annual Rare Disease Day conference right here in Ottawa. And it will be a great opportunity because we're going to provide a 5-year update on what has happened under the banner of Canada's rare diseases since that time. And we're going to be actually having the opportunity to look at the different sectors of that strategy and what it is that we've been able to move forth. In some ways that is absolutely amazing, but it hasn't been done by us, it's been done by everybody here. So thank you very much for that. I also want to acknowledge Tina as well. We had such an incredible support from Jonathan, and he meant so much to everybody here. So always, always, Jonathan's in our hearts. Thank you. Also, our recognition as well for Cancer Day. I think it is so important. And just to Natasha's point, sometimes people ask us, are rare cancers rare diseases? We say, of course rare cancers are rare diseases. You know, why would they not be? And I think we are increasingly seeing more diseases that will come under some rubric of rare because of the way it's being defined. But that's a good thing. It's not a scary thing. I think it really helps us to look at where we're going in terms of being able to diagnose and to be able to provide access to patients with these conditions in a very, very precise way, right? So we've never seen more exciting times in terms of what the opportunities might be in terms of being able to diagnose and treat people as individuals, very much so. Which is why the task today for us is so much more harder. Because what we recognize is that as much as people like Natasha are saying, without the innovative medicines, we wouldn't be here today. My mom wouldn't be here today. My husband, who has Parkinson's, you know, we recognize the importance of these kinds of therapies. On the other hand, we also have the hard task of recognizing that Canada may find itself really in somewhat of a unique position of not being able to access these medicines for our therapies. And this is not fear-mongering. This is not something that's just a possibility. It is a very, very close probability if we do not take a different course. So we call this the fight for our lives because it really is the fight for our lives. And I think that's why we've got it set up the way we are. I mean, the PMPRB, as you've heard, is actually introduced and passed now with this last parliament. As I say, in the last gasping breath of that parliament, passed the written regulations for modifying the Patent Medicine Prices Review Board. The mandate, I think it's important to recognize, is their mandate is actually to protect Canadians from excessive drug pricing. And that's important. Nobody wants to pay excessive pricing. Nobody wants to pay more than they need to. But to also recognize, though, that, in fact, it has no mandate to protect our health. It has no mandate to make sure the health system is more effective. So their singular focus is on pricing. They used to have a dual focus, as somebody reminded us this morning, and that is they used to have a focus as well on promoting research, but somehow that seems to have been forgotten about. And what they've now done then is introduce a number of important changes in the regulations. I'm not going to go through them all because they're actually fairly quite complex and there's lots of nuances in them. The two most important things for us to know is that one is that they are going, I mean, their goal, right, is to look at, you know, what is the right price. And as we all know, there's no magic right price. But what is the right price? What is a non-excessive price? And it's based on a number of factors. Two most important is what's the value of the medicine? And secondly, what are other countries paying? Which, without a clear other barometer, makes some sense. What's the challenge? Well, the difference we've seen, and we've tried to put it into 3 simple points. So those of you who have been fighting through the guidelines, et cetera, and not making sense of it, these are the only 3 things you really need to know, okay? So I've made it easy. First thing is that they've changed the number of countries, the number and the countries that are used as reference countries. So what's the right price? Well, what's the rest of the world paying? Because it is an international market. Used to be 7 countries. They've dropped the 2 top countries, which are US and Switzerland. They've added 5 other countries, which ostensibly have lower pricing. Quite frankly, we are not too troubled by that. We don't know exactly whether or not that's really the right thing to do, but it will, in fact, reduce prices, maybe something around 20% as the list price. The other two things that are happening that we consider to be most important that are much more problematic. One is that they've actually, for the first time, not just regulated the list price. You know, it's like buying a car, right? It's the sticker price. You may not sell it for more than that. This is the price. They also now are regulating what would be the negotiated price. So if you can imagine you go in and you negotiate for a car, now what they're basically saying is that down from the list price, we're going to mandate what it is that you may not exceed in terms of that negotiated price. Now that's very different, as you can imagine. And they're using some kind of a cost-effectiveness pharmacoeconomic index to do that. We have a lot of problems with how that index is applied to the innovative medicines, but that's not my intent to delve into that deeply here. It is being used already to some degree by our health technology agencies, and for the most part, we end up with some kind of a reference negotiated price. And what's happened in practice is that you've got a list price, you have the health technology assessment agency that says this is kind of what we think that value price should be, and you negotiate in between. What is it that the budgets can afford? What are they willing to pay? What is it that companies feel they need to get in terms of return on investment, and certainly a return on investment from Canada, to make it so that we can continue to be not only profitable, but to be able to invest further. So that's been the case, and that's the case worldwide. The challenge now, though, is that, in fact, the third point, and that is we're now going to put an upper limit on what that can be. If it's an ordinary drug, a drug for a common condition, it will be $60,000 per quality adjusted life year. If it's a rare disease drug, it will be $90,000. The challenge on that is in fact an amazingly, amazingly low price. It is a price that most companies would not be able to meet. It's a price that's far lower than any of the prices that we've seen coming out of the health technology assessment in recent years. So now we've got an actually cap on how much you can negotiate down to. So this is a big problem, because what it basically is saying to companies is that if you bring in a drug, you're going to be able to sell it for a lot less than you might be able to sell it anywhere else. And go back to the notion of a reference country, it means that that price then, if it's referenced by other countries, will actually drive down the overall pricing. The other thing to know about this, 60,000 and 90,000, quite frankly, and I sat on the steering committee, it's an arbitrary number. There's no evidence to say this is the right number. There's no evidence to say it's actually the right number in order to either make it affordable or to bring in other drugs. So this has been our challenge so far. So we're very concerned about what this means. Certainly the signal in terms of whether or not you want to bring a drug into Canada, whether you're going to bring it in early. I'm not going to belabor this. This is something that you see. This is how they're actually stepping that through. It's not, you can look at it, and those of you who know it will, have had some experience with it. But it still say that this is the process by which they'll have different categories of drugs, some of which will be really subject to this, and the others which are actually lower priced, non-innovative drugs, which may not be, or tend to have a lower budget impact. This is just, again, not to belabor it, is to just show kind of what the difference is between now and what's been happening. Whoops, sorry. Is that used to, as we say, we've had a list price, we had a health technology assessment price, and we negotiated it. Now, instead of that being the case, we have a list price, we have a value-based price, and we will actually have a cap that they will say cannot be more than that. And again, far lower than any other that you might see. And I give this as an example sometimes. In our last couple of drugs that we've seen for rare diseases, they're saying it cannot exceed 90,000 per quality adjusted life year. You don't need to know what that means in order to appreciate when I say to you, the last two drugs that we saw came in at 1.2 million and 2.4 million per quality adjusted life year. And so when they say we can find a medium in there, I'm kind of going like, under what circumstances? And, so this is the challenge that we've got. No other country is going into this approach. No other country is doing it this way. It will make Canada uniquely different from the rest of the world, and will make it very difficult for us to assure that we're going to continue to have those drugs. As I said, we are just doing the analysis now, but we would guess that of the drugs that have come in, certainly for rare diseases, and for many other diseases as well, if they're innovative drugs, if we applied the same standards to those drugs in the last 5 years, more than 90% probably would have not passed that criteria. So it means that they would not only not come, it would have actually probably meant that companies wouldn't even have bothered. So this is our challenge that we've got. And when we're saying it again, this is something that we need to be very much aware of. This is how, sort of my last real slide for you. So we can see where we have been in the past in terms of the light blue are the countries we used to compare to. That dark, dark line suggests that if we use the new basket of countries, where we will be now. I'm not so sure that we're terribly concerned about that. That's sort of the median of the OECD countries. What we're really concerned about is if you add in and factor in the cost, value-based cost factors that they're suggesting, we will be at the very bottom of that line. We will be paying or asking for drug prices that are probably the equivalent of Slovenia. Think again on what that means for a country like Canada to say our maximum drug prices that we will be able to reimburse you for is the same as what Slovenia is paying. Which companies are coming to Canada? Which companies are coming to Canada first? Which companies are putting their clinical trials in Canada? This is our concern. And when you just walk through it, and we're very, very concerned. I mean, for some of us who sat on that steering committee over the last 9 months, year, we tried to raise many of these objections. We felt that there was very little opportunity to actually penetrate it, and we were quite right. At the end of the day, by the time we got through that process, we were pretty much in the same spot as when we started. So this is a challenge. So I'm just going to leave that with you. I just wanted to do the highlights. It isn't just us as patients. It's not just the companies that are raising these concerns. These are all the groups that have raised concerns. And you should know is that there were consultations that took place early on, but none of those consultations were ever published. None of those consultations were actually debated. Certainly none of those consultations were given to us as a steering committee to say, oh my gosh, what is everybody saying? Is there in fact a better spot that we ought to be in? I'll leave it at that. Thank you very much.
Yeah, and then Thank you, Durhan, for explaining the context of this event and laying the foundation for the discussion to follow. Now, prior to introducing our moderator to the stage, one quick housekeeping matter. We will be taking questions from the audience, so I do encourage all of you to cultivate your questions. And when cued, you can just make your way to the front of the room. There's 2 microphones there, and we'll probably have time for 3 or 4 questions from the audience. So, without further ado, now it gives me pleasure to turn the podium over to former national news anchor and chair of Global Public Affairs, Mr. Tom Clark.
Hi and good afternoon. I have a little bit of laryngitis, so those of you in the drug field, if you could see me afterwards, I'd appreciate any help I could get. I'm just going to ask my panelists to make their way up onto the stage, if I could. Here they are. And as they're sitting down, I'll just say that when we get to questions, which we will, from you, just because of the time constraints, if I could be hearing the formulation of a question within the first 20 seconds, I would appreciate it. If I don't hear that, I may intervene. Anyway, fair warning. Hi. The very colorful Durhan, as you know, doesn't need any more introduction, but you're a key part of this. Let me ask all of you, just introduce yourself very briefly and tell me why you're here.
Chris McLeod, I'm a lawyer by day, but I also have cystic fibrosis, one of the rare diseases we're speaking of, and I'm on one of these drugs that's costly but life-saving. We can talk about that later.
Terrific, thank you.
I'm Dr. Yves Bolduc. I'm from Quebec. I'm a family doctor. I've practiced full-time, and also I am the former Minister of Health in Quebec. I'm here because I worry that when I read the New England Journal of Medicine, when I read the Lancet, I will see treatment for my patient, and it won't be possible to have it in Canada and in Quebec.
Thanks very much. Tanya.
I'm Tanya Stefanski, and I'm an academic researcher at the University of Alberta. And I think I'm here because I've studied the international landscape in terms of policies related to the reimbursement pricing in other places around the world.
Great. And Durhan, we know all about you, but why don't you give us one line?
No, that's it. I am also a parent of 2 children who are both born with rare disorders, so that's one of the ways in which I'm involved. I actually will tell you something exciting. My daughter-in-law is pregnant with our first grandchild, and she just sent me the note to say, because my son had a rare heart condition, right? So they wanted to know his heart, the baby's heart is absolutely fine.
Bravo.
A couple of notes for the panel. First of all, this is an informal discussion. If you hear something, don't wait for me to ask you to join in. If you hear something, join in. And that's a very gentle way of me saying, if you keep your remarks brief, we can get to cover a lot of ground. The other thing is, on behalf of myself, every MP in the room, every senator in the room, and especially for the political staffers in the room, please talk to me like I'm a toddler, okay? No big words, no fancy concepts. It'll go much better for all of us if that's the case. So Chris, let me start with you. As you described, you have real skin in this game. You're here because of the advances in medicine and the drug treatments that you can take to keep you upright. This new regulation, how is that going to affect you? What do you see in the next couple of years once this is implemented?
Well, the regulations as currently put forward are devastating for people with cystic fibrosis. There is a drug right now approved by the FDA where Americans en masse are getting access to it called Trikafta, which is a game changer. I'm on a drug called Kalydeco, which is the first of 4 drugs. Kalydeco or Cambi, Trikafta is the latest. Kalydeco helps a small set of CF people like myself. To give some context to it, in 2012, and let me put one comment about the Canadian system, it's worked phenomenally well for CF people up until gene modifiers came in. When I was born in '69, life expectancy for someone with CF was 6. Now I'm 50 and it's 2019 because every drug and medication that came on the market was instantly made available to Canadians. We had great care. 2012, we had a huge fight to get me Kalydeco. I was less than 30% lung function, 4 liters of oxygen a minute. My doctor said, you won't make it till Christmas. We got compassionate access to this drug. I went from 30% to 60% lung function. And I was 5 out of 6 months in the hospital pre-2012, pre-Kalydeco. 7 years I've been in once and working full-time. So it gives you a sense of the stakes. 50 people with CF expire every year. This year, put it in context, there's 150 people here, 50 people, if they couldn't get Trikafta this year, will expire. So we're talking body bags if people don't get a drug. Now, I was fortunate to get a drug and get out, but the PMPRB changed, to circle to your question, and Durhan went through the details. But we have a drug. It's a game changer. Those patients won't get access. And I'm blessed with a private plan. Even if you have a private plan, if the company won't submit to Health Canada because it can't get through the challenges at PMPRB, patients are out. We're the only country right now on the CF file that doesn't have a deal for Orkambi, one of the drugs, the precursor to Trikafta. So it's very concerning, very challenging. Although I think there's a path forward. I remember the quote from the 80s where someone said, what are the 9 scariest words in the English language? Well, if you have CF right now, they are, hi, I'm from the government and I'm here to help. Because while I know the intention is well intended, people don't mean to do something wrong, the reality is these amendments to the regulation are causing great mischief and concern to CF patients.
Okay, that's a perfect lead into you, Eve. Because you're looking at this through 2 different hats. First of all, as a former cabinet minister, somebody inside a government organization and looking at it from that perspective. And also, you're a practicing physician. So I guess that kind of makes you an honorable doctor, which is kind of nice. But from your perspective, from your perspective, do you agree with Chris? We got a crisis on our hands?
Absolutely. And just a lot for people who will die, people who are sick. Because you have new treatments, they're going to cost a lot of money. but they are very effective. And you don't know if you, your children, your mother or your father will have a new disease that's going to be treated. And the best person to defend the cause is the patient and the family of the patient, mother and father first. And as a health minister and as a doctor, I think the same thing. When I was the health minister, at one moment, they bring me a case with 3 cancer drugs. And they told me that it was too expensive because of the $60,000 and $90,000 a year quality life. And I was the first minister to decide to give the medication to the patient. Why? Because when you're sick, you have only a few months to live. The last month of your life are much more important and precious than when you are in the middle life and you have another 30 or 40 years. And with new techniques and new technology, Chris is the best example. You don't know what's going to happen in the research, that you're going to be alive again, not for 1 month, 2 months, or 3 months, for the next 10 years. I have a patient with cancer, a very, very fast evolving cancer. And she was supposed to die after 6 months. With 2 or 3 years later, she's still alive. Because at every moment, there was a new drug who came on the market and were able to give her. The new drugs that don't want to do publicity, Keytruda, Optivo, they have changed our practice. And we have to defend the access to these drugs. The new rule, the problem that we're going to have, before the price, we must have accessibility to the drug. The first problem, the big companies who do research and want to have the drug on the market, maybe won't come in Canada. Because if you have not enough patients to be treated, and it's very expensive to do to have the permission to put it on the market, they're going to stay in the US, but they won't come in Canada. Mm-hmm. The second thing is that we must have to pay this medication. And I think it's good. It's a good thing that we have to negotiate. But we have to negotiate something that you know that's going to be much more expensive because you have to pay the research for a few patients or sometimes for something new. The third thing for me, and some people don't see it, but as a health minister, it was very important, is we do a lot of research in Canada. We participate with the international research. We develop products, and research is the economy in Canada. Ontario, Quebec, Alberta, British Columbia, other provinces have research centers. And if the company don't come here to bring their medication, they don't do research, it means that economically it's not good. And also we don't have access to new drugs that are going to come in the market. In Quebec, I have many patients who have new drugs that they would be on the market, and they have access to it because we're doing research. Because of these 3 things, it's very important that we defend the access to the medication, and I think we should negotiate or try to be sure that the company won't leave Canada and we're going to be alone. Like I told you a few minutes ago, if you read the New England Journal of Medicine, the Lancet, you're going to see what's on the market. If your patient cannot have it, the price is not important. They cannot have it. That's how.
And we are going to talk about the perhaps unintended consequences of shortages of these drugs in a minute. But Tanya, I wanted to ask...
It's not shortage. You don't have it.
Yeah, that's an extreme shortage.
Yeah.
That's when you're down to 0. Sort of like the results from Iowa. We don't have them. Tanya, I wanted to ask you, because you were a member of one of the federal working groups that's studying the implementation of this. From your pretty unique perspective on that, what is the government getting right? What are they getting wrong? And what's missing out of the piece?
Well, the technical working group was asked to focus on specific pieces given the policy intent that was specified by the PMPRB. So when we were looking at things like even what's the right cost per quality adjusted life year, it was, I think anybody who can read the report will see that a lot of it was, well, we don't really know, because there wasn't an opportunity to do additional analyses to explore other options. So I think it's fair in the read of it that on every element. We did, when there were concerns, we raised those concerns, but we didn't have a clear option of an alternative because that would have required further analyses, additional resources that simply weren't within the time frame of that whole committee meeting. So I think that's the short answer to it.
Okay. Duran, just to complete this round, I want to come to you and pick up on what Eve was saying. And you're right, shortages or not, non-existent. It does remind me, and I heard this story, happened to be in Newfoundland, but I'm sure it's happened in other places as well, about the woman who, on her way to work every day, sees this sign outside a grocery store that says, 10 pounds of potatoes, 50 cents. And she sees this day after day, and finally she says, yeah, that's a fabulous price for potatoes. So I'm going to go in. So she buys 10 pounds of potatoes, and the storekeeper says that'll be $10. And she said, well, wait a minute, your sign said 10 pounds of potatoes, 50 cents. And he said, oh, that's when we don't have potatoes. When we do have them, they're $10. So in a way, Duran, that can sort of, picking up on what Eve was saying, that the unintended consequence of all of this could very well be that the major providers and companies providing these drugs, developing these drugs, will simply bypass this country. In other words, we have a cheap price. The only problem is we don't have any drugs.
It is a very, very troubling scenario. I have to say, though, I didn't quite understand Tom's story. Maybe it's because I'm not from Newfoundland. I'm sure there was a gem of wisdom in there, but I didn't quite get it. But that's okay. We can talk about it afterwards, okay? But beyond that, I think the challenge is exactly as you say, though, is that we know that, I think as Dr. Bouduc says, the investment in terms of research and clinical trials comes from companies who are actually wanting to not only just market a drug, but to understand more about a condition, to promote centers of excellence around those kinds of conditions, and sometimes even without necessarily being a treatment part of it. So that investment is hugely important. But then clinical trials, as we know again, predicated on the belief that we're going to be able to demonstrate the value of the drug and then be able to bring it onto market. But if, in fact, we're in a position in Canada where that drug is not going to actually be marketed or even be marketed for years, companies are not going to come here because under our ethical guidelines now, if a patient starts on a drug and that drug is working in a clinical trial, you may not take that patient off the drug. And in fact, in many cases, if patients have been on the placebo arm and that drug is working, you cross them over to actually get the drug as well. So again, if the scenario is that that drug is not going to come here for many years, it puts us in a tremendous disadvantage in terms of being able to get access. And again, when we raise these concerns, the pushback we get, oh, that's just fear-mongering. Of course companies will come here. Reminding again, Canada, for all the great healthcare system and the fact that it is a great place to actually bring in drugs, we're 2% of the world's drug market. So again, we're trying to pretend we're going to be the tail that wags that dog. Let us be very, very clear. We ain't wagging no dog. All we're going to do is be flicked off like a flea.
I just want to put a question to anybody who wants to jump in here. And this is on behalf of legislators who have to make big money decisions on things. So give me your best pitch as to why it is that with an increasing array of incredibly expensive drugs and an increasing array, seemingly, of rare disorders that can only be handled through these drugs, when you're handling the provincial finances or the federal finances, does there not come a point, though, at which you say, if we just approve everything, we're going to go bankrupt. These big multinational drug companies are going to take us to the cleaners. It may be beneficial for a very small group of people, but you can imagine in politics, it's all about making choices. How do you justify the enormous cost of these things against, I can see everybody wants in on this. Chris, you start, and then Eve,
Okay.
you go ahead. Yeah.
I heard a great anecdote from a former deputy minister of health in Ontario who's now running part of the drug piece on the Auto Trust. And they decided to place Orkambi, one of the CF drugs, on their formulary and remove the second most expensive drug medication, which was baby aspirin. So baby aspirin was the number 2 line item. And they were going to remove it. They went to the union workers, they had to pitch it and explain it. And they said, we're taking baby aspirin off because almost everyone was on it, covered. And one gentleman stood up and he said, well, now I know why one of the particular auto companies went bankrupt. They're paying for baby aspirin and not paying for the game-changing, life-saving drugs. So yeah, you're going to have to make choices. But a lot of the choices that can be made, if you look to what is a game changer and moves the dial on keeping people on the ice in the game of life and not, then I think the decisions are not going to be as challenging as we might think they are. Let's not get caught up with sticker shock on the price. We're dealing with negotiated prices ultimately.
Okay, now we got babies with headaches all over the place.
First,
Eve, you wanted it.
What you said is not true. Okay. Because
I didn't say anything. I asked.
I'm going to explain you. When I was the health minister, people were saying me that it was very expensive, the new drug. But what you didn't see is that we save money to other drugs. Just give you an example. Lipitor was very expensive. It was like $80 million a year. Now it's cheap. And now the heart disease is very cheap to treat because we have new generic medication. We took this money, $360 million a year in Quebec, and we put it in the new drugs. At the end of the day, in 2012, just go to check. It was less expensive in dollars to treat a patient, to treat the system for the patient than in 2011. It was less expensive. The other thing, when you have someone that you can treat, he can work, he's going to pay taxes. Chris, you pay taxes?
A lot.
Okay, that's Chris pay taxes for other people. And don't forget, in Canada, it's an insurance principle. It means that you don't know what you're going to have. You don't know if your house is going to be on fire. But you take insurance to be sure that if it happens, you're going to pay for it. It means that I'm going to pay if I'm still in health, but I'm going to pay for someone. You can be me, it can be my mother, my sister, and my children. It's an insurance principle. Some people it's very costly because they don't have the chance to be in good health. The other will pay for them. But you don't know in the tirage if you're going to be the one. This is why it's important to have a system that pays for the diseases that are very common, that it's not so expensive, and to have an insurance for the diseases that are very expensive. And at the end, what it costs a lot today would be much less expensive in the next few years. In genomic, we were doing sequencing. The first one, I think, was like $10 million. Now it's $700. It means in the meantime, if you look on the long term, it won't be more expensive, except you're going to have better treatment, and we're going to have also the technology to be able to treat our people. And don't forget, one part of money is just not to pay the patient, we pay the companies. The company come back and do research, and we have jobs that are very good for the economy of Canada. Because of that, I think at the end of the process, and although it's not something that's going to cost a lot tomorrow morning, it's a progressive cost, and we have to plan for the next 10 to 15 years, because not every disease is treatable at this moment, but we hope that in the next 10 or 15 years, we'll be able to treat more diseases than now.
Tanya, now that we've fixed your microphone, have you got anything to add to this?
I
Now that
think
we can
so.
hear you? Yeah.
So actually, to pick up on your point, part of that is Quebec versus the rest of Canada in terms of how you value new therapies. So Quebec takes a payer's perspective as well as a societal perspective. So all those things that you talked about are taken into account. And one of the things that we did talk about in the technical working group was perspective and the opportunity to take a broader societal perspective. And of course, some of the pushback, which is legitimate, was around the methodology about how to do that. But Quebec has done it quite effectively using more qualitative type approaches, so not needing to capture it in a single figure or an algorithm, to still be able to ensure that that broader view of value is taken into account, because otherwise you get a very narrow perspective, which is basically the payer's perspective, the drug budget, and that actually limits you in terms of how you can actually see what value you actually are getting from a drug. And when you look internationally, the UK, those of you who know this landscape, the UK is often seen as the gold standard in terms of negotiation around reimbursement and pricing. And they take, in the case of rare disease drugs, the perspective of both the patients, the families, and the caregivers. So it is a broader perspective.
But you bring up something interesting. I just want to jump on this for a second. you praised Yves for the work that Quebec has done in this area. And you talked about the UK. Well, the UK is basically a unitarian state. Well, for now. That may change. In Canada, how many health systems do we have in this country? At least 12?
13.
13, somewhere around there. So what about the inequality of treatment? We can talk about generally the theory behind all of this, and we can talk about the federal programs and so on, but it does come down to, if you're a resident of Prince Edward Island, are you going to have the same access to this sort of thing than if you lived in Quebec or BC? I mean, we have a very fractured system in this country.
Can I just add, Tom? There's another group to that, which are the private employer benefit plans.
Right.
So almost 50% of Canadians have robust private plans. I have a small business. We have 26 people, and we've got a phenomenal plan, which covers off everything from Remicade to Kalydeco. So we need to help increase the number of people captured by the private plans. And an idea for the parliamentarians, most employers don't look at the premium as they look at it as an expense. If you made part of the premium a tax credit, then employers may get more robust plans, and you can move from 48% to 72% of Canadians covered. So it's not that everyone's going to be on the public reimbursed plan. So it's a bit of a misnomer. And the second and last point, the patent is only for the life of the patent. Once the patent's over, then generics can come in and the price again dramatically falls. So, and it's one of the things the PMPRB is not taking into account, nor is CADIF and others, that the life of this, the pricing life with a patented drug is just the life of the patent. Then generics come in. So we're already 9 years in negotiations on Kalydeco. Well, if the life of there's not much more left on the patent. Last comment.
So can I, I'm not going to answer the question directly, because I think if I were to ask the question, how many of you know where there's wastage in the healthcare system? How many of you would know where there's wastage in terms of even in drug dispensing and utilization?
For sure.
Right? I mean, it's to your point, right? There's lots of places where we can get that money that actually would more than compensate for what we know. And I've said to health ministers, or even drug plan managers, if you don't know where it is, we can find it for you. If you can't manage that drug budget to cover it, give it to me, I can do it for you. I mean, quite frankly, there is the money there. I think the other thing we recognize, as we've heard, is some of these therapies do take a lot up front. And more, the gene therapies, the curative therapies are going to take a large amount up front with big payoff down the road. And I've had people say to me, yeah, we recognize that this is cost effective and it actually is going to work, but I don't have the space, the head space to cover it. The problem is we can't figure out how to finance this. I'm not saving people's lives, so we can't change our financing. And we've said we can amortize it. Well, we don't have the systems that would allow us to do amortized payments. Again, how many people do you have working in finance? You can't figure this out for us? I mean, quite frankly, we all have mortgages. We know how this works, right? There's lots of ways. We're very heartened by the fact, for instance, in the last government, they actually announced that they will have a $1 billion rare disease drug strategy. What we're seeing is it's not to pay for drugs, it's to create that headspace. It's to set up the monitoring system. And we're really grateful, actually, to Tanya and Dave, from PRISM, because they're the ones that are going to be helping us put this together. And I know you can't talk about it yet because it's still in progress. But we're very, very grateful, and we're hoping to be working with, with that group, because we believe there are strategies that are there. And if the only thing we need to do is to figure out how we can shift some of that monies up front or to amortize it out in order to make it available so we can see the savings down the road, good grief, we can figure that out, right? That's an accounting issue. That is something that we know how to do.
Yeah, I will give you two examples that what we do now is not an expense. It's not an expense, it's an investment. Crohn's disease. When I started my practice, Crohn's disease were very sick. They didn't work. They were always in the hospital. They cost a lot of money. Now with the new medication, they are treated as an outpatient. They don't go to the hospital. They do it in the clinic. They receive their medication, and they can work, and mainly they're in good health. This is the present. The future, sickle cell disease. If you have seen the article a few days ago, there is no treatment going to come for sickle cell disease. People are very sick, and now we can do a modification of the gene. It's going to cost a lot of money now, but later it's going to be less expensive. And what we do for the sickle cell disease, we can do it for many of the 5,000 rare disease, because research is going to be much less expensive, and what we learn for one disease, we can apply to other diseases. And Canada is centered to that, because we're very good, we have a good reputation in the world for genomic. Every one of our center in Quebec, research center, works on genomic. This is the future. In Quebec, we are working also with artificial intelligence. And when you combine both, you're going to have a new industry that can be in front of everyone in the world. And I think at this moment, there is a risk. Because if you do not have companies who works with us, and they decide that Canada is not the good place to stay because it's too expensive for them, they go to the US. And with the new immigration law in US, we don't do politics, many people cannot go to US, but they can come in Canada. And Canada and US work together. Boston, New York, San Francisco, Los Angeles, Houston, they are centered, that my center in Quebec, work with them. And we do research because now research is not a one place. It's a multi-sit research, and we participate. This week, if you go in the Lancet, we have research from Institut Cardio de Montréal. 3 weeks ago, Jean-Claude Tardy published in the New England Journal of Medicine. It's the same thing in Ontario, in Alberta, British Columbia. This is why we have to defend the access to the medication and to be able to treat our patient with the new medication that's going to be on the market in the other part of the world.
Just want to let everybody know that we are going to go to questions. If you have a question or a comment that sort of sounds like a question, you can go to the microphones now. And as we're waiting for you to get up there, I just wanted to pick up on one last thing that's sort of common to everything. And I asked it before, but it was the federal-provincial split on how we deal with this question in this country. How you, Eve, have just said it's multidisciplinary now. The whole world is working, and yet we see very different priorities in provinces, especially in this area here. How do you get around that, especially because, and Tanya, if you've, actually, Tanya, I know you can't talk publicly about what you're doing, but just between us. Well, what do you do to get rid of the uncertainty, which is such a drag on, not only on the industry side, but on the patient side and even on the government side? The creation of this uncertainty can't be doing anything good for anybody with a stake in all of this.
So part of it, though, is that what we're working on isn't related to the PMPRB guidelines. It's the supplemental process that's being proposed for a certain category of drugs that are usually considered the for life-threatening conditions where there's a lack of alternative. That's a path that's being proposed for the review of those drugs. So it's not about the PMPRB per se, and that's looking at, well, the uncertainty around there would be really addressed through adaptive processes, these managed entry agreements. The problem with that would be typically those work well because they're confidential. They allow for those negotiations at basically a national level. What we don't know is how something like the PMPRB guidelines might affect the rollout of that, because no other country has that system like what we might have. So it's an unknown. So there's a big uncertainty there to even get to the point where what we were working on would matter.
Anybody else got a quick comment on this before we go to the audience? Sir.
Is this on?
Just let us know who you are, too.
Oh, yeah. Oh, okay, there. Now it's on. My name is Charlie Thompson. I'm here from Healthcare Can. Healthcare Can represents the hospitals, health authorities. It's a bit of an administrative question, I guess, which is, for Category 1 medications, these are the more expensive or larger market medications. They are subjected to a review process that takes into account their value. This is what Derhain was talking about earlier. And my question is, that pharmacoeconomic analysis is done by CADITH or INES, and if that information is not available, you're basically given a rock bottom price, or the very lowest price that can be calculated by the PMPRB. My question is, does that create an administrative barrier to entry if you have to, you used to not even have to go through reimbursement review or pricing review if that's what you chose not to do. Now you have to go through it first, which means that the or my question is, would that mean that the pipeline would be longer than it would be previously? Because CADTH is governed by, these organizations are governed, I know I'm taking a while. The organizations are governed differently. CADTH is governed by the deputy ministers of health from the provinces and territories. INES is governed and accountable to Quebec, and they don't share a workload or administrative information well with one another. So does that is that a reasonable expectation of all of this, or do they behind the scenes have they sort of managed that?
Can I just go and take a quick stab? You sound very confused
Oh.
about this process, and you know what? It's not your fault. They've deliberately made it very confusing. When we sat on the steering committee and asked, who is going to do this economic evaluation, they said, well, we're not real sure yet. What if there are differences between what CADTH does and INES does? What are you going to do about that? They said, well, we're not real sure about that yet. So when is this going to be done? When we go to CADTH and said, are you guys doing this? And they say, well, nobody's told us that we're going to be doing it. Well, at what point in the process is it been done? Because now it goes after approvals, there's a pricing set, and then we do that pricing adjustment, right? Now they're saying it's going to come ahead of time. Is that going to be the case? They said, we're not real sure yet. So if you're confused, you got it, because it's a very confusing process, and this is what we're begging for. Could we just slow down? Don't put out these muddled guidelines, which even very intelligent, knowledgeable people within the system can't get. Give us the opportunity to do a proper consultation. Give us an opportunity to really look at how it's going to impact the drugs that are proposed to be coming in. Give us the opportunity. We beg for case studies. Let us take a look at how it would affect. I gave you my, kind of off the cuff kind of a what the impact might be, but that's just me kind of, doing it on the back of an envelope. We got to do better than the back of the envelope if we're going to bring this in. So I didn't mean to make fun of you in that way, but yes, you've got everything right, because they don't know, and we're just begging. Let's work on it, let's get the process, let's test it out, and then we roll this out. Let's not just throw them out there with this kind of confusion.
Yves, go ahead.
First, I believe that INES for Quebec can do a good job because they look at the value and not just the price. I was the minister who put INES in place. I did the law about that, and we had the it was very important for us. It was just a question of price. It was a question also of accessibility and to have the right value for the right price. That is very important. The problem of INES, and you know that INES did an arrangement with one company, and we're going to have CAR-T treatment in Quebec. We have the minister, Daniel McCann, who is doing a very good job in Quebec, did an arrangement with them, and our patients are going to profit for CAR-T, and it's very expensive, but we were able to negotiate with the company. And but the risk at this moment is not that they cannot negotiate, that they cannot have it. If the medication is not in Canada, it's not possible to have it. And in Quebec, we have what we call patient d'exception. If you're not in the formulary, if you have the right, if the medication is efficacious or your treatment is efficacious, there is a possibility to have it. The patient d'exception is very useful for us, and the patient can have the treatment. At the end, what is important? If it exists, if the treatment exists, we should be able to give it at the right price. What I can see is possible to have the right price, but it's not, if it's not available in Canada, at this moment we have to go to the access, special access from federal, and it's going to be very difficult. Okay. It means that many patients in Canada with rare disease, cancer, other diseases, won't be able to have the same treatment than in Europe and in the US. That's the conclusion at the end of what we talked today.
Yes, sir.
I'm Sandy Sadev, medical oncologist from Ottawa. I came back from my practice in the States in '92 because I was so offended after 1 year by the disparities in access to care. Wealthy business people having to bankrupt themselves to get on Medicaid to afford cancer therapies, even in those cheap drug days. So now I'm faced with a shocking fear based on these discussions, what's going to happen to my patients. A lot of cancers are sort of rare diseases now because we have them spliced by subtype and subtype molecular characteristics. This stuff is all just conceptual, but as of last week, I've been notified that one manufacturer has decided not to apply for a breakthrough drug in breast cancer, a subtype of breast cancer, because they don't see it passing this bar. There's another breakthrough drug that was probably the biggest announcement at a Texas breast cancer meeting in December that already is on the market in the States because of fast-track approval that we think may be 5 years for our patients to get. So it's hard to sort of phrase my thoughts in a question, but one thing is, how do we appraise the impact of these challenges and these lack of access issues to so many cancers? How do we appraise the impact on our patients? Mortality, quality of life, who's tracking that? How do I explain it to my patients? Right now, we have published data from Dr. Stewart in Ottawa showing that thousands of patients a year in Canada are dying because of delays in access from our existing drawn-out processes. We have a very fair process here. I'm very pleased with the rigor of review, but it's too slow as it is. How do we explain it to the patients? And how do we get the governments to really realize the impact of this really on these rare diseases? My understanding is this process is really a one-size-fits-all for all new drugs. But there always has been a realization that, there are rare diseases that CORD deals with, that cancers are uncommon. We have special cancer registries, special cancer, programs and agencies in the provinces. There needs to be some kind of exceptional mechanism or an entry door of a different level for those conditions. So
let's let Chris answer
that's
this.
all I can ask.
Well, it's challenging. You've got to tell the patient to advocate for themselves. When I was in the hospital in 2012, the doctor said, Chris, we can get the drug on a special access program, and it's supposed to have a 24-hour turnaround. 5 days later, we didn't have a response. So access delayed is access denied. So patients need to advocate aggressively for themselves. But on the point of timing, it is really critical, because I was on a panel with Durhan, and 2 days later, I was in a hospital. Well, I went from I was obviously not that well when I was on the panel, but the time between you're well and you're not, it's a blink of an eye. And to get out of the challenges caused by the healthcare crisis that an individual's in, you need all hands on deck. So for the parliamentarians in the room, time is of the essence. When you have a healthcare crisis, use a Super Bowl analogy. It's like all of a sudden you're going to the Super Bowl of a healthcare crisis, but you haven't trained for the sport, you haven't had any coaching or practice, and all of a sudden you're in the Super Bowl of your life. And it does not end well if you've got teammates or medications that can help you get through it and you can't get them, because that game ends when the clock ends.
Okay.
So it's a problem.
Just for time purposes, yes, sir, go ahead.
Maybe just
John Adams from the Best Medicines Coalition.
Sorry, John, 1 second.
Hang on a second, John.
I just want to give another answer. I was a politician. I'm a doctor. I did research. And I can tell you, at the end, the one who's going to decide how it's going to be are the politicians. Because, when I worked with INES and I created INES, when it was decided that the patient with cancer are going to have the medication, it's not INES who decided, it's the minister. Why? Because as a politician, I take account from everything. Not just the costs of the medication, not just what I know as a doctor, what the patient needs, and the patient is our citizen. And at one moment, if we don't have access to some medication that it's possible to have in other countries, the one who can decide to discuss with the bureaucrats, which are doing a very good job, are the politicians who can decide about that and who can at least ask questions if it's the good thing for the population not to have access to the medication because we think it's too expensive.
So it's ultimately a political question.
Ultimately, it's a political question, because after that, the people who are working in the office can decide differently. And the things that is going to be too expensive, I don't believe that. Because at the end, the best medicine is the cheapest medicine. Not because it's not a good medicine, because at the end, it's going to save for the people who can work, we can have people who can live longer, and we can have family and patients who are happier if they have the good treatment.
Here.
Sorry, we interrupted you. Please go ahead.
Thank you. My name is John Adams, representing the Best Medicines Coalition. It used to be a crime in this country for a doctor to assist a person to die in dire circumstances. Now we have medical assistance in dying, not because of our politicians, but because of the 9 judges of the Supreme Court of Canada. But if patients have the charter constitutional right to medical assistance in dying, doesn't that mean we should have the charter constitutional right to medical assistance in living? And isn't it time for patients, not just drug companies, to ask the judges of this country to take a deep dive into how decisions are getting made about access to new therapies, and isn't it time for patients to speak up and speak up to the courts?
Would anybody like to disagree with them?
No.
Okay.
Can I just add to that?
Yeah, briefly.
30 seconds.
Go ahead, Tanya.
No, you go ahead, because we had this talk before.
Okay, so I have two actions going, one in British Columbia right now, where we're raising that very issue of a Section 7 charter right, and it deals with CADIF and others. And we've intervened in the jurisdictional litigation in Quebec on the PMPRB reform. So I think patients do need to litigate in the court and raise charter and constitutional arguments.
Tanya, did you have a word?
I was just going to say, he's got the examples.
Oh,
Yeah,
okay.
yeah.
But can I ask Tanya to actually provide very quickly something? I mean, one of the challenges we've had is that we have not actually put forth alternatives. Part of it is because we have not had the opportunity to, but I think you were giving some examples today about what other countries do. Maybe you can just sort of reprise kind of what does Germany do when it has one of these innovative therapies that are coming in, and we look at what's the different approach for making those available.
Well, see, but just from a context perspective, though, the examples I gave were all cases where there's a universal pharmacare system, either a statutory-based health insurance system like Germany or a tax-funded system like the UK, where when you're determining reimbursement, you're determining prices, you're doing it on a national level. So what Germany does, and this is why they rank really high in terms of access to these innovative medicines, is that at the time of regulatory approval, that drug is automatically available for 12 months at the manufacturer's price. And if that amount, the budget impact in that year, exceeds a certain number, so exceeds 50 million euros, then it goes into discussions around the additional therapeutic benefit. And then they heavily use discounts and confidential price volume arrangements to get it down to something reasonable. But what they also do is they give innovative therapies a chance to almost prove themselves in terms of the added benefit by having a way to collect additional data over a 2 or 3 year period and then revisit that price. So it provides an opportunity for sort of that chance for things to prove themselves right, not necessarily right at the front end, but through a time period that's more legitimate where real world evidence is collected about how effective it is. But Germany is the only place in the world where regulatory approval is really your ticket to at least reimbursement for a full first year.
Okay, we have run out of time for questions, but I have noticed that you're standing there. Can I ask you a favor? Sure. Can you say something interesting in 30 seconds, and then we'll wrap it up? Sure. On.
So the key here is that Canada believes that they have a universal health care system, including access to drugs. And if we believe that, then nobody should be left behind by our governments, political, at the federal level or the provincial level. And so I would agree with Sandy Sadev, and I would agree with you, Durhain, and thank you very much to all of you for putting this together, because this is a conversation we have to have. The court that actually matters here is the court of public opinion. And I think that public opinion, if they could understand it, would say, no people with serious illnesses, with life-threatening illnesses, should not have access to medications that keep them alive. So what I would say to PMPRB is, you're absolutely right, Durhain. It's a case-by-case basis. These guidelines may work for some people some of the time, but we need a system that will work for everybody all of the time. And so we need to take our time and do this right.
Thank you very much. And on that note, I will just thank the panelists, Durhan, Tanya, Eve, and Chris. Thank you very much for a really fascinating conversation. I appreciate it.
And thank you, Tom, for leading such a thought-provoking discussion. I'm so sorry, due to time restraints, we do have to finish off the conversation. I know there were some individuals in the room that did want to ask a question, so I do encourage you to visit the head table as soon as this is over so you can get your question heard. But we do have one final speaker. I'm delighted to welcome Madame Biba Tinga, Vice President of the Sickle Cell Disease Association of Canada, who will come up here and officially close out the show. So welcome.
Thank you. Good afternoon, everyone. Thank you for putting together this event for us, and thank you to Cord and Derhen for inviting us and giving me the opportunity to speak in front of you today. I have to say it's been a very interesting conversation, and I think I came here, I was already, worried when I was, always following this discussion, all this process, and looking at all this guideline. But now I'm going to leave here, I think I'm totally scared. I am scared because I'm looking at what's coming at us, and I represent the sickle cell disease community. I'm the president of the organization, and today I have to go back to them and report to them, to a community that has been asking questions. So just to put it into perspective for you, sickle cell disease, is a genetic disease that affects the red blood cells. So. And about 6,000 individuals live in Canada with this condition. And for over 30 years, we've only been with supportive care. And life expectancy is very short, about 50 years old. And people are living longer with the progress in medicine, but they are going through a lot of challenges. And just to put a face on that today, I came with two gentlemen today with me. Joseph Wolobangi, can you stop taking pictures and stand up? Thank you. I'm going to introduce Joseph to you. Joseph Wolobangi was born in Quebec. He is 46 years old, and he went back to Africa. He grew up in Nigeria and Ghana. And then at the age of 26, he came back to Canada. And Joseph has sickle cell disease. Today, Joseph's life revolves around hospital and home. He's been on the blood exchange program for 17 years because that was the only option left for him. And he has organ failures, kidney failures, a heart condition. So now Joseph is on dialysis 3 times a week. And then he goes for the blood exchange again every 7 weeks, Joseph, to the hospital. And that's all that is available for Joseph. So I wonder, as a society, what are we doing for Joseph when new medications are available? I don't know if it's even going to be for him. Maybe for somebody like Joseph, maybe gene therapy can offer an option, And I just want to think about that when you think about all these new changes, that it's affecting lives. Because all this conversation that has been going on, I think it's looking at the cost, not the benefit for the patient community, for human beings who every day are struggling. Recently, I had a call for another mom who has 2 young adults with sickle cell, and she told me, Biba, I only have 4 years to fix this situation, otherwise I'm going to lose my children. And we cannot let that happen. As a community, we are going to stand strong. We are going to ask because we know that, access to care, access to medication, when they are available, because it is available now, it should be a basic human right. So we are going to advocate strongly. We are going to stand as a community and ask for it. Thank you very much for being here, and we are going to continue the conversation. I really like the fight for our life, le combat de notre vie, because this is exactly what we are doing every day to support our community of people living with rare disorder. Thank you so much for being here. Thank you.
Oh, no, I did that.
Hi there. Just to let everyone know, you're quite all invited and your families on February 29th. As you know, it's Rare Disease Day. First time ever, our flag will be raised at Ottawa City Hall. A flag raising ceremony at 10 a.m. I'd love to see you all there, help bring awareness and support our community. Thank you.